All right, so we're going to go over diagnostic testing, screening, and mitigation for COVID-19. The objectives are to explain current mitigation strategies, review testing characteristics, understand the differences between screening and diagnostic perspectives of the same test, look at multivariate models and how they predict, and then what does it mean to test for COVID infection versus immunity. So the first part is to just look at mitigation strategies here. And so in this slide, you can see that there's a pool of susceptible people here. And you can kind of think of them as falling through a COVID trapdoor. And it has a certain size to it that allows a certain rate of infection to occur. And over a period of time, we'll call this the period prevalence. And so the size in this gap here is related to what that period prevalence is. And then down below here illustrated is the healthcare system safety net. And as long as the period prevalence is as small or smaller than the safety net, then we have an adequate distribution, an ability to meet the needs of those that are coming to us. And as these patients come to the safety net, the majority of them are going to become recovered, while a minority are going to die. And so the safety net is not a perfect safety net, and not everybody walks away safe. But this helps to illustrate kind of the general principle of what's occurring in the population, where you have this general population of susceptibles becoming infected, and then a healthcare system that needs to meet the need to mitigate that. And as we relax mitigation, you can see that that the period prevalence is going to increase, and that the size and the hole in the floor is larger now. And so there's more people falling through that are becoming infected. And at this point, we still have an adequate match between this period prevalence and the healthcare system safety net. And this is kind of where we are at the moment. Now, some of the interesting things that are occurring is that the safety net's getting a little bit smaller as staffing is getting contracted across different hospitals. And it's anticipated that some critical access hospitals, as time goes on, may not have the funding to be sustained. And so the idea that the healthcare system and as a safety net is going to expand rapidly, I don't think should be very well anticipated. There are specific areas where we can try to mitigate that, and we've seen that already with the capability of delivering a response either from the Navy providing Mercy and Hope as facilities, as well as other potential military and or federal support. But we really don't have this and shouldn't have this huge expectation that we're going to necessarily be able to staff all of that and meet that. So the current safety nets that we have are probably expected to contract a little bit more, and at the same time, we're going to see this period prevalence increase with relaxed mitigation occurring. Still, the majority of patients are going to be recovered, and there's still going to be a minority that die. Now, when the period prevalence begins to increase significantly, it can exceed the safety net. And this is when things become more dangerous, right? So the size of the hole of the floor is much larger than what the safety net is capable of catching. And so we begin to see additional injuries that result from the lack of healthcare resources. And this doesn't just apply to those that are infected, but also includes those with other diseases that require the healthcare system safety net. And this is what we saw occur in Italy, what we saw occur in Ecuador, what we've seen occur in a number of different other places. And the hopes are that if we see this occur where the period prevalence increases and it's greater than the safety net, that we will be able to instigate mitigation strategies again that would return us to this ratio of matched patients to safety net. And the ability to move from here to here requires compliance, right? So we have to have a certain degree of compliance where people are maintaining social distancing, and where there's different attitudes and behaviors that allow for this. The likelihood that we're ever going to return to as strict of a mitigation compliance ratio as we did when we started is probably very low to nil. So again, the hopes are that once we see a period prevalence that may exceed the safety net, that we can then enact additional mitigation strategies to return us to a balanced ability to meet those needs. Now, when all of this was being mathematically modeled, the model was an unmitigated model. What would happen if we didn't have any social distancing, if we didn't actually use any means of trying to mitigate this in any shape or form? And that's something that was initially modeled, and what we saw from the Imperial College of London, and also from even Harvard's initial models had included an unmitigated response. And that wasn't necessarily a response that we thought would definitely happen, but it was like, what's the worst case scenario of how bad can this be, right? And so those were the models where we're looking at 30 million deaths in an unmitigated way. That's not very different than the models that we see in financial models right now, where we look at what could occur if the economy doesn't recover. Well, then you have this unmitigated idea of a severe economic depression and significant financial collapses of markets and so on and so forth. Does that necessarily mean that that's going to occur? Probably not, because there'll be mitigation strategies that would be employed to reduce that. And the idea would be that as we use those mitigation strategies, can we use them to an ability to have an adequate balance between what those health resource needs are and what the patient's needs are, in a way that they're actually being met. And that's the experiment that's going on currently in many different ways, right? We're seeing Sweden use a mitigation strategy, and you can see that their death rates are increasing considerably in comparison to their neighbors, but at the same time, they don't seem to have overwhelmed their health care system as yet, and so they would still be considered kind of be in this kind of ratio. Any questions about kind of this? I realize this is kind of a simplistic way of doing it, but I think it kind of illustrates the point a little better.